everyone, I am Dr. Rachel Matthew, the founder of All Things Women. All Things Women is an online platform geared to educate women and their partners on sexual and reproductive health. In the month of October, globally known as Breast Cancer Awareness Month, we'll be going through different aspects of breast cancer and how it can affect the lives of women and their partners and family. For this video, we'll be going through chemotherapy and its effects on the body and the life of a woman. We have with us a very special guest. Her name is Dr. Joye Taylor Houston. She's a consultant hematologist and oncologist at the Kingston Public Hospital and an associate lecturer in pathology at the University of the West Indies since October 2013. Her areas of interest include leukemias and lymphomas. She's married with 3 children, and she's here to help us discuss the topic on chemotherapy. Welcome, Dr. Taylor Houston.
Thank you very much. Happy to be here.
Awesome. On the topic of chemotherapy and radiation too, I should add. Now, chemotherapy is a poison, but it's also a lifesaver for so many women who are trying to beat breast cancer. And it's a poison in the sense that it not only attacks the cancer cells, but it also attacks healthy cells. And I'm not even going to beat around the bush, because I'm sure many women, those who are about to start chemotherapy or who have started, one of their main worry is fertility and how chemotherapy and radiation affects their future desires to have children. So can you shed light on that particular topic and what exactly chemotherapy does to the ovaries?
Thank you very much for that question. Well, the short answer to that is that fertility is preserved because the medications that we use to treat breast cancer, the primary ones are, of course, the doxorubicin, cyclophosphamide, and one of your taxanes. Patients can still become pregnant even after having received these medications because these are not associated with infertility. They can cause temporary amenorrhea. So the patients will stop having periods while they're receiving the chemotherapy. But usually, well, depending on the age, so if they're young and still well in their, fertile period, usually the periods will resume. However, for patients who are close to menopause, or maybe patients who are in their late 40s, who probably would have been close to natural menopause, some of these patients may actually go into early menopause. In other words, they may not resume having periods after completion of chemotherapy. But once they are less than 45, usually, periods will resume and they can still get pregnant. And there have been reports of persons who have gotten pregnant after completion of chemotherapy.
So for those women, because you said that for some period in time, they might go through a stage of amenorrhea where they don't see their period at all. Can you give an estimation, based on your observation, how long a period that would be, especially after the chemotherapy has ended? What is the average time before you have these women see their periods?
I can't give you an exact figure, but because some persons obviously, it takes longer than others, but usually within a year, most of them will have resumed having their menses.
Okay, have any of your sorry, you were saying something else?
But some of them, it can take longer. It can take maybe up to 2 years.
Up to 2 years. Have any of the patients who have become pregnant after the chemotherapy treatment experienced any difficult pregnancies in that they have ended up in having children with birth defects or any sort of syndromes? Have any of your patients come back?
No, well, the few that we that have become pregnant, no, they have not had any problems in terms of birth defects or any sort of, defects of the infant.
So what is the conversation like before chemotherapy starts as relates to fertility, well, future desires for children? What's the conversation like in terms of advising the women accordingly?
It's not something that we actually bring up when we are
Oh,
discussing chemotherapy. I mean, it's usually if the patient asks.
okay,
If the
gotcha.
patient asks, I mean, most of the patients that we see actually, most of them pretty much have completed families. I don't know if that's why the question doesn't really come up that often. Because I mean, in Jamaica, that a lot of the persons, they start having children, fairly early. So usually by the time the average age that we see, which is like in the 40s, most of them have actually, completed their families already. But we don't. It's not a topic that we usually bring up. But if unless the patient asks.
Okay. And I'm guessing based on what you just said, there has been little need to refer such patients eventually to fertility specialists based on
Right.
what you're telling me. Okay. All
Right.
right. Understand. Awesome. What about the radiation now? Because I know radiation is a totally different type of treatment. That can that have an effect on fertility? I know I'm stuck on this fertility question because I know women are are really concerned. So most women are concerned about having children. And so what about radiation? Can that have an effect on fertility?
Well, I mean, radiation for the breast should not, because
Oh,
of course the radiation would be at the area of the breast,
yes.
and the axilla. So, and it's local treatment, so it wouldn't really affect fertility. However, in some persons, you may, for anti-estrogen effects, you may want to radiate the ovaries. And in that case, if you have to do that, then of course, they would no longer be fertile.
And that goes to my next question. I wanted persons to know the difference between chemotherapy and radiation and the difference in side effects as well to those two treatments. How different are they and what are the side effects associated with them? And what
I mean,
governs whether or not a person does chemotherapy versus radiation for breast cancer, that is, breast cancer treatment, of course.
all right. So, I mean, they are very different because chemotherapy is a more systemic kind of treatment because for the most part it's given in the vein. So it's more systemic. And of course, the aim of chemotherapy really is, maybe I should start off by saying that, I mean, the choice of treatment, of course, is dependent on the stage. And of course, breast cancer is staged from 1 to 4, 4 being metastatic disease. And of course, the stage is going to tell you the likelihood of call as well as metastatic recurrence. So basically, that's what the treatment is aimed at. So basically chemotherapy is given to reduce the likelihood of systemic recurrence, in other words, metastases along liver, bone, while radiotherapy is more of a local recurrence. So the radiotherapy is just targeted to the area of the breast, the chest wall, and of course the axilla. Of course, you have patients who will undergo, you can do either mastectomy or you can do lumpectomy as treatment, surgical treatment for your breast cancer. Of course, patients who undergo lumpectomy, because there is going to be remaining breast tissue, those patients have to undergo radiotherapy to the breast because you recognize that you're leaving behind breast tissue. You don't know if there are cancer cells left behind in there. So of course you'd have to radiate to try to kill those. But of course, if you underwent a mastectomy, you'd have removed breast tissue. So it would only be given for patients who have what we call locally advanced or have multiple nodes, axillary nodes, because as I said, those patients, the risk of local recurrence is much higher, so you give the radiotherapy to prevent that. In terms of side effects, well, of course, the side effects are going to be much different because radiotherapy is, because it's a local treatment, it's really just local side effects. So usually it's at the site of where they're getting the treatment. So, I mean, I'm not that adverse in terms of the side effects, but I mean, they get things like, of course, they can get burns at the sites, or they can get irritation. So usually, you know, the patients are advised to keep the area dry. You know, they can't bathe, they can't use lotions, powders, deodorants, anything like that that will, you know, further cause further irritation. And of course, they will get the hyperpigmentation, but usually that goes away after a while. And of course, chemotherapy, as you had said in your opening statement, is that, you know, it affects not only just the cancer cells, but other cells. And because it's given systemically, it can basically affect cells in the entire body. So the effects of the chemotherapy is more widespread. So in terms of the medications that we use commonly for breast cancer, which, as I said before, is your adriamycin and cyclophosphamide along with a taxane. So of course, hair loss is going to be one. You can get nausea and vomiting, especially with the cyclo combination. But of course, we usually give antiemetics. We give medications to prevent vomiting, both IV prior to giving the chemotherapy, as well as tablets for the patients to take at home. Of course, it can affect the blood counts, usually not severe, but some patients can actually, white cell counts can actually get very low, and it can actually pick up infections, what we call febrile neutropenia. They can get local effects as well. So for your doxorubicin or your adriamycin, they can get extravasation if it leaks out, and you can actually get ulcers at the site of where it leaks out. Your Taxol, you can get like nail changes. You can get local reactions if it leaks out. And of course, the doxorubicin has cardiac effects. So patients have to undergo an echocardiogram prior to starting therapy. And of course, if they have any cardiac issues, then we have to look for alternative treatments. And the Taxols can cause neuropathy. So they can get tingling of the fingertips, numbness of the fingertips and the toes. And of course, that can be of varying degrees as well. And basically treated symptomatically. However, if it's severe, we may have to either reduce the dose or we may have to change again. Because sometimes it can be severe enough that it affects function because of the numbness. So they can't use their hands well because of the numbness. Sometimes they have difficulty with the feet, they can't wear shoes, you know, things like that. So if it's severe, we may have to change the medications altogether.
Woo! That's a lot of side effects. What's usually the reaction? Patient is counseled prior to chemotherapy when all of these side effects are listed to them. What's the reaction when they hear all of these side effects?
Well, I think the thing is, you know, that most of them seem to come already having some idea of what to expect. So for most of them, it's not like, you know, they're hearing this for the first time and it's, it's frightening because, you know, they talk, and I mean, they go to a surgery clinic and, they're there with persons who have, had chemotherapy. And I mean, even in their communities and so a lot of them actually come already having an idea of what to expect. So it's not so frightening to them. I think they may, and even the hair loss, I mean, a few of them will express, a little concern about that. But I mean, I guess in this day and age, we have so many fashionable wigs and, I guess it's not that much of a concern. I mean, you can, as you had said, you can do your wraps, how to wrap your head and, all of that. And I mean, some of them look quite stylish when they do it.
For those patients who hear these side effects and decide that they don't want to do chemotherapy, what is usually the next step in counseling them? Seeing that chemotherapy is going to be a big part in the treatment, how do you go about handling that?
If we have any patients who, maybe what I should probably say is that most patients, by the time they come, I think most of them would have already made up their mind what they want to do. Because as I said, most of them already know about chemotherapy. So most of them come either decided that they're going to go ahead. So regardless of whatever you say, they have decided that they're going to go ahead. And then there are those who have decided they are not going to take it. So regardless of whatever you say, they have decided. So, I mean, we just try to counsel them, just try to, because a lot of times, they have misconceptions that they hear from other persons. So, we usually try to get to the reason, why it is that, you don't want it. If it is due to misconceptions, we try to, straighten that out. Some of them will come around because some of them realize that it's actually not as bad as they thought it was or they heard it was. Some of them are still adamant. And I mean, you can't force somebody to do something like that. So, I mean, we just have to counsel them on, the risk, the reason why it's being done, the risk if it's not done. And then once they understand that, I mean, this is the risk that they're taking, I mean, we just have to abide by their decision. If they are hormone positive, meaning that they're either estrogen or progesterone positive, then of course we just put them on the anti-estrogen and then send them back to the surgeons for continued follow-up. But fortunately, we don't really see a whole lot of those. Most persons are actually, I mean, they understand the risk, but I mean, they also understand the reason why it has to be done.
Okay. One of the side effects that you mentioned was infection, high risk for getting infections. Saying that in general, chemotherapy and radiation weakens the immune system, causing women to have a high risk of getting opportunistic infections. Is there any sort of medication that is given to help strengthen the immune system during this time of treatment?
No specific medications. I mean, we usually just tell them to, because I mean, the most of the risk of infection is from neutropenia, which I mean, there's really nothing much that we can do about that. So we usually just advise, avoid. I mean, it's easy now with Corona because, a lot of these things are being done. So we, advise them to avoid crowds, avoid people who are obviously sick, because they will be at increased risk of picking up whatever they have.
Yes.
Some dietary, probably not so much with the breast cancer treatment, but maybe with some of the other treatments that can cause more severe neutropenia, we'd advise like avoiding, raw vegetables. So things like carrots, cabbage should be cooked as opposed to eating raw. Tell them to avoid things like
Why is
lettuce.
that so? Sorry to cut you. Why is that so for persons who are wondering?
Because remember that, you have all kinds of bugs on these things. So for persons who with competent immune systems, that's not an issue. But then persons who are, neutropenic or immune systems are compromised, then these bugs and, other things that are found can become problematic in them.
Okay, so that risk for, I guess, parasitic type of infections.
Right.
Okay, gotcha.
Of course, if a person because I mean, as I said, occasionally, some persons may actually become severely neutropenic and may actually end up being admitted to hospital for febrile neutropenia. So for those persons, for subsequent treatments, then we usually use the colony stimulating factors, filgrastim, to prevent severe neutropenia. And that is given post-treatment so as to prevent severe neutropenia. But those are the only persons that we really use anything like that in, because most persons do not usually end up with febrile neutropenia. Of course, just to mention here that some persons may, hear about it. You have what we call a dose-dense treatment, because normally the treatment is cycled every 3 weeks. And of course, the 3 weeks is to allow for the natural recovery of the blood counts. But for certain persons, especially persons who are getting neoadjuvant breast cancer, so like, those who with a very large breast mass, who, if you were to do surgery up front, closure might be very difficult. So those persons get neoadjuvant. So for like those persons, we actually can give them what we call dose dense. So it's the same medications, but instead of cycling it every 3 weeks, it is cycled every 2 weeks. But But because at the end of 2 weeks, usually the marrow would not have recovered by then. So those patients would routinely get Neupogen in order to speed up marrow recovery to allow them to be able to get it every 2 weeks.
Okay. So I'm guessing that's the closest thing in terms of medication to help strengthen the immune system.
But I mean, we don't usually, I mean, of course, you advise your normal diet, your well-balanced diet. Some of them ask about supplements, like vitamin supplements. So we said, I mean, no problem, things like a Centrum and one a day women, whatever, vitamin, multivitamin.
Are they also referred to a dietitian?
Not usually, not unless there's a problem.
Okay then. See, I've gone through all of the side effects and the differences between chemotherapy and radiation. Now, for a person who is set to do chemotherapy or someone who has just been recently diagnosed with breast cancer and is wondering what exactly is the experience of chemotherapy, and walk us through experience of chemotherapy in the chemo unit at Kingston Public Hospital in terms of what their frequency is like, in terms of what to expect when they enter the unit, the way the medication is given. I know you have mentioned it throughout the interview so far, but just to bring all of that together for those who are wondering what's like.
So in terms of treatment at the unit, first we have certain days of treatment, usually Monday, Thursdays, and Fridays are when chemotherapy is given. So when the patient comes, usually the nurses will, because most of the nurses that we have in the unit have done an oncology course, so they know a bit about, the treatment. So they will usually, go through them, tell them what the treatment is about, what to expect, sign a consent form. And then usually what happens is that, because we have one or two doctors in the unit. So what happens is that when they come in, and of course they are counseled again, they get their accesses cited, and then usually we start off with the pre-medications, that's the anti-vomiting stuff. So they usually get 3 medications. So that is given. And then after that, they will get the actual chemotherapy. For the AC, A stands for adriamycin, C stands for the cyclophosphamide. So they usually get that one first. So you usually get 4 cycles of that, and that's given every 3 weeks. That one doesn't usually take long to give because basically for both of them, we just dilute it in a butyl with some saline, and it's running like over 50 minutes. And as I said, and then of course we usually flush after because the adriamycin is very irritant. And then that is given every 3 weeks for a total of 4. And then of course after that they will switch over to the Taxol. And then usually for the AC, they're usually seen in the clinic prior to each time they do the treatment. So 3 weeks they are seen in clinic, they do the blood counts. Once the blood counts are fine, then they are scheduled to go down for the treatment. For the Taxol now, the most common regime that we use is a weekly regimen, and they get 12 of that.
Sorry to cut you off. For the blood count, what is the acceptable blood count for persons who are going through chemotherapy?
Well, it depends on what medication they get, but for the AC, the neutrophil count that we accept is 1.5. So once it's 1.5 or more, and platelets once is above 100, they're good to go. For the weekly Taxol, the ANC is a little lower. We accept an ANC of 1. So once it's above 1, they're good to go. So the Taxol is weekly for 12. So we don't usually see them every week. It's very difficult for them to be coming to clinic every week. So usually we probably see them once for the month. And then what we'll do is just advise them to do the blood count every week, and then they go down to the unit. The Taxol takes a little longer to give because you have to give your pre-medications, but it's a different set of pre-medications because it doesn't usually cause nausea and vomiting. But you can get, I didn't mention this, you can get allergic reactions with the Taxol, especially when you get it for the first time. So you usually have to give things like DPH and steroids. And then after you give that, they usually have to wait about 30 minutes before they can actually commence the Taxol. And then the Taxol is given over an hour. And it's every week for 12. And as I said, we see them like once a month. And then the in-between times, they just do their blood tests. And then they go down to the unit and then they are given their treatment. Depending on the crowd in the unit, like Fridays are usually fairly empty. So, I mean, you know, they might just take the morning. On a day like a Monday now, which is very full, pretty much might be there, you know, for the whole day because, of course, we only have a limited number of chairs. So sometimes, you know, we may not be able to, you know, treat everybody at the same time. So, you know, some persons may have to wait.
How many chairs do you have?
We have about 15 chairs. We have about 15 chairs.
So for the
and of
most,
course, we use the pumps as well. We use the infusion pumps so that, you know, they can be timed. So there's also a limit in terms of the numbers of those as well.
So how many infusion pumps are there? 15 as well?
Yeah, we probably have a bit more than 15 because sometimes depending on the patient, we might just have them sitting like in a regular chair and they can get the infusion as opposed to sitting in one of the recliner chairs. But usually the patients come and the patients, you know, they you know, become accustomed to, you know, how things operate and stuff. So, you know, they know what to do and those, you know, bring their food and, you know, whatever.
That's a whole day. Basically, it's a whole day.
It can be, yes. It's at least a morning. It's at least a morning. And depending on the day you go, it may be a whole day.
Yes. And one of the side effects I just thought of, I don't recall whether or not it was mentioned, but it's difficulty in the veins, getting the veins. The veins can be sclerosed. Yes.
Right.
Yes.
So patients who have poor venous access, because remember that the doxorubicin is quite irritant. So if it extravasates, it can cause some serious burns. So for patients who have poor venous, and then remember that with the breast too, that usually we tend to do the IV access on the sites, the unaffected site. So we're already down to one upper limb. So, you know, other things that we have the option of 2 upper limbs.
What's the reason why it's only on
the reason is basically for, well, it's for lymphatic drainage because, you know, they would have removed the lymphatics.
Yes.
But I mean, it's not that it can't be used. Because if somebody has had a bilateral mastectomy, then I mean,
yes, you have to use something.
And then if we have problems getting venous access in the hand that's not on the side with the mastectomy, then we may have to use the other side. But I mean, it's not a first option. But of course, for patients who will realize are going to have difficult venous access, then usually they're encouraged to buy a port. But then the problem is that not a lot of them can afford a port. And of course, you're going to have to buy the needles to go with the port.
How much does a port cost here in Jamaica?
The port costs maybe around 30,000. And then, of course, depending on where it's put in, there might be a cost. But we usually send the patients to National Chest. So they go there, there's no cost to put it in. And then the needles probably cost maybe about 1,800 a needle. And of course, have to use a new needle each time. So, right. So a lot of them can't afford. So we just have to try. And as I said, if you can't get an access in the hand, you know, the non-mastectomy hand, then sometimes, you know, we just have to use the other hand.
That's really a lot for one person to take in. It can be mentally draining. Even you going through all of it, me listening to you, it is mentally draining me. So I can't even imagine for persons who are going through the actual thing. Is there, well, routinely, are such patients normally referred to a psychiatrist, or maybe not even a psychiatrist, but a psychologist or some support group or a counselor to help take them through this process because of the mental drainage that can be associated with this?
Well, unfortunately, you know, how the system is set up, we don't really have ready access to something like that. Of course, for persons who are really having challenges in adjusting, then, I mean, those patients would be referred. Unfortunately, we don't have it routinely that, every patient can be referred for counseling to, help them to deal with the situation. So it's just those who are really having a challenge coping that we would refer.
Okay. Is there a support group though? The public hospital?
I know Cancer Society used to have Reach for Recovery. I'm not sure if that is still, so that is a group and for breast cancer. But as I said, I'm not sure if that is still in existence. But I mean, I guess they could call Cancer Society and find out. But I know they used to have the Reach for Recovery.
Reach for Recovery. Okay.
But that's the only one that I know of.
Well, thank you so much, Dr. Taylor Houston. I really appreciate your time that you have given to us through this virtual discussion. Just one more thing for a young lady that has recently been diagnosed with breast cancer and who is set, let's say she's set to come to your clinic or to an oncology clinic. What advice can you give to her as she starts this journey of chemotherapy?
What we would say to somebody like that is, I mean, we acknowledge that, I mean, it is a difficult time because, I mean, it's dealing with a diagnosis like that, especially, as a young person, and then, having to go through the treatment to the side effects. So, I mean, we, acknowledge that, but then we just try to encourage them and just, tell them, just take it one day at a time. Mm-hmm. I mean, it will come to an end at some point, and just think of, what we're trying to achieve by all of this. And then basically that's what they should focus on. Instead of focusing on what they are going through at this time, focus on the end point and, what we want to achieve, and that this will come to an end, at some time.
Thank you
and to
so
just think positive. Because, positive, the mind is a very powerful thing. And
yes,
if you go in with a mind thinking of all of the negatives, then you're not going to have as easy a time as if you think positively.
Yes, that is so true. Thank you so much, Dr. Taylor Houston. I really appreciate it, and I really hope for those women who are going through this time that you continue to stay strong. If it is that you need some mental support and you feel as if you need to speak to someone, please let whether it is your oncologist or your breast surgeon know of it so that they can possibly refer to someone. Thanks again, Dr. Taylor Houston.
And thank you again. It was my pleasure.